Good morning. Before I even start, let me thank the organizers and also Dr. Chesko for talking about anxiety. I have discovered that during COVID, some of you have seen my cat wandering through here, a great way to deal with stress. The other thing I've discovered is that because of these Zoom calls, I can live in a different world. That is, that painting wasn't real. I can sort of pick my painting. So suddenly I own this collection of Monets that don't exist. It's delightful, takes care of stress. So thank you all for talking about anxiety. Let me share my screen and go on with the talk. I am Michael Fossel. My background is a couple of degrees in psychology, followed by moving into neurobiology and then into clinical medicine and dealing with actually trying to cure physical ailments. I'm going to follow much the same arc in my discussion today. That is, I'm going to talk a little bit about psychology of the dementias and the neurobiology, and then about the medicine of them. And I really do want to talk about curing the dementias, not simply just dealing with them, but actually trying to reverse and prevent them. So again, I thank Dr. Chesko for pointing out that 30% of people at certain age groups do have dementias. When we talk about dementias, most of us are well aware of things like Alzheimer's and Parkinson's or frontotemporal or posterior cerebral atrophy, as well as vascular dementias. But even this diagram here suggests something that many of us know is real, which is there's overlap. For example, many patients with Alzheimer's have motor components. Many patients with Parkinson's have cognitive problems or executive function problems or memory problems. Likewise, frontotemporal or posterior cerebral atrophy, and particularly true with vascular dementia. That is, we see very few patients with any of the dementias who don't have some vascular component, and vice versa. And the same is true when we sort of expand that and talk about many other dementias. There's an entire alphabetical list of dementias that may run into dozens at this point. But many times what we talk about these days are also atypical dementias, because I think we recognize that, you know, as Dr. Chesko says, everybody's sort of their own norm. There are normal Alzheimer's, but everybody's a little different. And we see whole conferences globally on atypical dementias because they are atypical. They're also mixed dementias. It's very seldom that we see any of these dementias in a pure form. They tend to have sort of borders that have a gray zone and drift into other dementias. And I think more and more people over the past decade or two have begun to recognize this, which is that all of them share some fundamental relationship, some age-related neurodegenerative component that's just true of all of them. So while we see both the pathology at the cellular level and the pathology at the clinical level having different expressions, at some underlying level, they share something fundamental in the mechanism that's going on. And it clearly has something to do with aging itself. And before I really get into aging, let me say that one of the reasons that I think we have failed to be able to cure or prevent age-related neurodegenerative diseases, that is the dementias, is because we make the mistake that I sometimes call the assumption of understanding. And this is sort of the psychology of this. We tend to assume that we sort of understand the basic components, and it's just a matter of the details, getting the details right. I think probably few of you know this hill. I know I've never been here, but some of you will have heard of it before. This is a hill from Shakespeare's Macbeth, and this was Dunsinane Hill. Now, in Macbeth, the three witches told Macbeth he would never be conquered unless Birnam Wood came to Dunsinane Hill. And his assumption was that he understood that, as the audience does. They think that's not possible. Well, what happens, of course, is Malcolm cuts down the wood, uses it to shield his soldiers, marches on Dunsinane Hill, and kills Macbeth. The problem is that Macbeth had this assumption of understanding. He thought he knew what was meant by Birnam Wood not being able to come to Dunsinane Hill, and he was wrong. The psychology then is what gets in the way when we're trying to deal with dementias. We think we understand it, but we really don't. We don't go deeper. Here's another example just from science, because we make the same mistake in science and medicine. Back in 1895, Lord Kelvin was probably the world's preeminent physicist, and he made this statement 8 years before the Wright brothers proved him wrong, although it took about another 5 years before the world accepted it in France, actually. But he knew a great deal about air pressure and a great deal about weight, but next to nothing about aerodynamics. So he made the assumption of understanding that obviously things heavier than air can't fly, and that's clearly wrong. We did the same thing with regard to physics. Back in about 1900, All of us knew about day-to-day things like billiard balls and soccer balls, but what we didn't understand was that at the atomic and subatomic level, that analogy doesn't apply. So most people felt that atoms were very small billiard balls and that subatomic particles like electrons and protons were even smaller billiard balls. But that had nothing to do with reality. And it wasn't until 1924 and Max Bohr, and then 2 years later, the Schrodinger equation, that we began to understand reality was a lot more complicated. But again, psychologically, we make the assumption of understanding, that we understand what things are, and therefore we understand what these very small things are. And that's simply not true. We do the same thing in medicine. I began practicing medicine in the late 70s, early 80s. And our assumption of understanding at that time was that all ulcers, for example, pyloric ulcers, were caused by stress and acid. And that was a reasonable understanding. It was wrong. It wasn't until Robin Warren and Barry Marshall published this article in the British Medical Journal in 1983 and pointed out that that little bacteria to the right, that's Helicobacter pylori, is the cause of, for example, pyloric ulcers, for which they won the Nobel Prize in 2005. But our understanding was flawed. It was understandable. It was reasonable. We thought ulcer, stress, but it had nothing to do with reality. We make the same mistake when we look at dementias. We think that we understand that the dementias are caused by things like beta amyloid and tau tangles, and that's true as far as it goes, but we don't go deeply enough and look at fundamental mechanisms. So we have a risk in our assumptions, and the assumptions are our problem. They prevent us from moving on. Some of you have heard of Dr. Leonard Hayflick. He's a friend of mine. I call him my favorite curmudgeon. And he made this statement to me a couple of months ago. He was the first person ever to describe cell aging. And what he is saying here is that all of us recognize that the single greatest predictive risk factor for the dementias is aging. We know that very few 10-year-olds get dementias and a great many 90-year-olds get dementia. But we then totally ignore the idea of aging, and we focus on things like the cellular pathology or the clinical changes without asking ourselves what aging has to do with it. And that's a mistake, because aging underlies all of this. The question is how. About 1.5 years ago, the Alzheimer's Association globally asked me to go to Washington to give a talk on an animal models talk. The problem we recognized in the field was that everything works in mice, nothing works in humans. That is, you can do all sorts of studies in mice, but they don't translate well to human clinical studies. And I was to summarize why that was. I pointed out a few things. One is that you and I share about 75% of our genes with mice, about 25% we don't. And almost all the animal studies we do focus on mechanisms that are part of that other 25%. So it's small wonder they don't translate into human studies. Now, the other things I pointed out was that we have techniques like monoclonal antibodies, and we have targets like beta amyloid and tau tangles and alpha-synuclein aggregates and so on. But what we lack entirely is an overall systems model to explain how all of these things work. And that's really been our problem. Let me give you a feeling for that. There are some underlying fundamental processes that are the same in mice as they are in humans, but we, as I say, are different than mice, and so they're expressed different ways. Example, beta amyloid is handled very differently in humans than in mice. So when we do studies on beta amyloid on mice, they don't translate well into humans. There are other things we share, but at a fundamental level, we share a great many things. It has to do with cell aging. The same thing is true of human dementias. So for example, if we look at things like Alzheimer's and Parkinson's and vascular and atypical dementias, they are all expressed differently, but they have the same underlying process, which is cell aging. And what we see is that the physiology and the cellular changes and the clinical presentations of these are all a little different. And that's because all of us are different as well. We are slightly different genetically, we're different epigenetically, we've had different behavioral experiences in our lifetime. So we tend to have different outcomes. I may have Parkinson's, Dr. Chescu might have Lewy body dementia. We have slightly different outcomes, but the fundamental process that underlies those is driven by the same process, cellular aging. So as I said back in Washington, what we need is a unified systems model. And a model like that has to have several characteristics. It has to explain the heterogeneity in Alzheimer's. That is, why do some people get Alzheimer's at age 50? And other people get it at age 90, and some people never get it. Why do some people get it more with a slightly more motor component, some people with more verbal component? Why is that so different between different Alzheimer's patients? The same is true of all these other dementias. Why do I get Parkinson's and you get frontotemporal? Why do you get vascular and someone else gets Alzheimer's? Also, we need to be able to explain cognitive decline in other species. Dogs, cats, rhesus, monkeys, gorillas, all tend to get cognitive decline in aging. And we need to explain all of that as well as just human. Also, we need to explain upstream mechanisms. For example, trauma, exposure to radiation, toxins. We know, for example, that if you have head injuries, you have a higher incidence of Parkinson's and Alzheimer's. Why is that? Not just it happens, but why does that happen? Also downstream. Why is it that if we look at the outcomes of these, some patients get beta amyloid plaques, some don't. Some get alpha-synuclein and death of neurons in the substantia nigra, others don't. Why does that happen? Not only do we have to explain all of that, but we need a model that is a systems model, not a components model. That is, we need a model that looks at the process, not simply all the little pieces of it, but how they work as a gestalt. And here's what I mean. On the left, you're seeing a Rolls-Royce Pearl 15 jet engine. On the right is the turbofan Trent 900 that powers it, and a single fan blade from that engine. Now, a couple of years ago, a friend of mine, who actually was in charge of overseeing the project that designed all of these things, said that I had a systems model of aging and age-related diseases. I asked what he meant. He said, I'll give you an example. That turbofan blade that you see in the foreground on the right, if that fails, he does not ask what's wrong with the metallurgy of it and the design of it. He asks what's wrong with that fan blade in that turbofan, in the Pearl 15 Rolls-Royce jet engine, in an Airbus 380 at 35,000 feet, going hundreds of miles an hour from continent to continent. That is, it's a systems question. That fan blade does not operate all by itself. It operates in a larger system. This is the same thing that we need to do with regard to medicine. Example. Here's a river that all of you have heard of and probably none of us have been to. That's the Ebola River. Now, most of you at this point are thinking that's a list of signs and symptoms of Ebola virus infection. And you're correct, that is a list of signs and symptoms of Ebola virus. But that is not Ebola virus. Ebola virus infections are not simply signs and symptoms. It's a complex interaction between a virus and a very complicated human being, resulting in a cascade of pathology and disease, and usually death, which I didn't list here. The signs and symptoms are not the disease. They're the outcomes of the disease. They're not the process itself. And what we need to get at is the process if we're going to make any headway. The same is true of aging. This is a list of some of the changes that we see in aging at the macroscopic level. For example, in medicine, we see that declining glomerular filtration rate, failure of the kidneys. But all of these are things that we tend to see in patients, in ourselves in the mirror, in people around us, and family members. We're well aware of these, but these are not aging. They're outcomes of aging. They're components, they're biomarkers, whatever you'd like to call them, but they're not the process itself. The same thing is true if we go down to the microscopic level. I could list hundreds of these. These kinds of changes occur throughout our body as we get older, but they're not aging. They're outcomes of aging. They're not the cause, they're not the process itself. They're simply biomarkers of it. We could go a little further and look at things like the dementias. For example, these are a list of typical findings that we see, including this blood-brain failure, blood-brain barrier failure, lymphatic changes, and so on. All of these are typical sorts of changes we see at the microscopic level, but they're not dementias. Dementias are not simply the outcome, it's the process that we need to understand, not simply the biomarkers of it. Now, a lot of us would say, well, it's the genetics of this, but the genetics are not the disease either. These are a list of many common genetic correlates of Alzheimer's. For example, if you have two ApoE4 alleles, your chances of having Alzheimer's go up, two ApoE2 alleles, they go down. But we see patients with two ApoE4 alleles who have no Alzheimer's, and we see patients with Alzheimer's who don't have those alleles. So the ApoE4 gene and any number of other genes like this are not the disease. They're correlates, they're risk factors, they're associated findings, but they're not the process itself. Again, we need to dig deeper. In science, we usually say that if you can't measure it, it's not science. But simply because you can measure it doesn't mean it's science either. It's not enough to measure it. What we need to do is go a little further and actually understand it. Because if we don't understand it, then it's not really science. It's simply a list of data points. The same is particularly true of medicine, because if we don't understand it, then we can't cure it. Once we understand something, then we can cure it. It's not enough to simply list the symptoms for Ebola. We need to understand what it is and develop, for example, a vaccine. Well, this is a problem that has concerned me now for about 4 decades professionally. And back about 24 years ago at the NIH, the National Institutes of At which point most of us would say, well, we expect the different species to get different genes. That's true, but aging works at different rates even within species. Example, these are a group of progeric children, about 30 of them. About 20 years ago, I used to gather them around from all over the world with Bill Sample there in the background with his hands up. And we take them various places. In this case, we took them to the White House. I took them places in the White House you were not supposed to go. I took pictures of things you were not supposed to take pictures of. And we had a delightful time until the young man in the left front row with a baseball cap, that's Sammy, and his friend in the Hawaiian shirt named Ori. The two of them sat down on a pressure sensor in the third step up just inside that door on the left that leads to the private quarters in the White House, in which case Secret Service very politely but very firmly escorted us out the door of the White House. Well, these kids die overwhelmingly of age-related disease. The average age of death is 12.7 years. They are bald. The kids you see who have hair are wearing wigs. Most of them are wearing baseball caps or scarves to hide their baldness. They have thin skin that sloughs easily, doesn't heal. They have osteoporosis. They have osteoarthritis. They die overwhelmingly of age-related vascular disease. For example, strokes and heart attacks at age 7, example. Why is it that that happens? We know the gene. We know there's a lamin A gene that's involved in this, but that's not the process. That doesn't tell us how it works. It simply identifies the gene. Many people think aging is not avoidable. Well, every person listening to me right now, every cell in your body derives from a fertilized ovum, most of which you got from your mother. She got that from her mother after a few decades. She got that from her mother, who got it from her mother. That line of cells goes back unbroken for 4.5 billion years. During that 4.5 billion years, that germ cell line never aged. It changed dramatically, but it never showed any sign of aging. And yet your cells show aging in your body in a matter of decades. The same is true of your mitochondria. Every mitochondria in your body derives from your mother, who got it from her mother. That line goes back about 1.7 billion years. Those mitochondria never aged for almost 2 billion years, and yet they instantly begin aging in most of your cells. If I were to measure mitochondrial function right now in you, I'd find mitochondrial aging in many of your cells. So why is it aging sometimes happens and sometimes doesn't? That's something, again, that's concerned me now for decades. I published the first book on this back about 25 years ago, the first articles ever in the Journal of American Medical Association, in which I argued that if we could understand aging at the cellular and genetic levels, we could actually cure and prevent age-related diseases. This was followed by what's still the first and only textbook on this field with Oxford University Press, very academic, 4,700 references, followed by a book for the general public, which the Wall Street Journal said was one of the best science books of the year. But the point I'm making is, I was trying to figure this out for a long time. I think all of us recognize that entropy has something to do with it. There's continual damage going on in all of our cells and all of our tissues. But what's the balance against it? So to give you an analogy, let me introduce you to some of my gardens. Gardens don't manage to live forever unless they take a lot of maintenance. A successful garden doesn't occur because you haven't got any weeds. It's because you continually are weeding. A successful garden doesn't occur because nothing's going wrong with it. It's because it's continually being maintained. The same is true of the cells in our bodies. So, for example, we know the germ cell line never shows any evidence of aging, and that's because it's well maintained. Maintenance actually continues to be entirely balanced against entropy. The same is not true with regard to that 80-year-old skin and the man feeding the bluebird to the left. He has the same amount of entropy that you and I had when we were children, but his maintenance has begun to fail, and that's why you begin to see aging. Let me explain it sort of at the cellular level. In a young cell, you tend to have long telomeres, which we'll come back to, and they modulate the expressions of genes. But every cell in your body has a particular pattern of gene expression. So when I was, for example, 10 years old, every cell in my body has a particular pattern of gene expression. And as I get older, I turn 70 this year. I have the same exact genes that I had when I was 10 years old, but the pattern of gene expression has changed. Same genes, different pattern of expression. The telomeres have shortened, which again controls some of that pattern of gene expression. It is not that I'm missing genes. It's not just that my genes are damaged, it's that they're changing their pattern of expression. We use another analogy. This is a symphony orchestra. If I take two symphony orchestras and if I take a symphony orchestra and one of them is playing Brahms and one's playing Beethoven or even the Grateful Dead or John Cage, the difference is not the instruments or the musicians. The difference is the score and the tempo. It's set by the conductor. In your cells, the telomere is the conductor. And in older cells, it is not that the first violin is failing or the oboe is dented or the piano's out of tune. The difference between a young cell and an old cell is the tune they play. It's the tempo and the score. It is not the instruments and the musicians. When I look at cell senescence or cell aging, a lot of people tend to talk about cell aging as just that last part at the right, the replicative senescence. We know that when cells divide, and they do throughout your life, there comes a point where some cells simply won't divide anymore. That's called replicative senescence. That's not the same as cell senescence. Cell senescence is the spectrum of change that occurs throughout your life. And that shows changes in gene expression throughout your entire lifespan. Some of these cells at the very end won't divide at all. So let me take you down inside your cells now. In young cells, the molecular turnover is very fast, no matter what molecules you're looking at. Example, if I look at the collagen and the elastin in my skin in between the cells, that's being turned over continually at age 10. Now my rate of turnover is slower. Now, in young cells, whenever you have any molecule, protein, lipid, doesn't matter, they're getting damaged, signified here by that little red star. But in young cells, that's washed out. You're continually turning over the molecules. You're recycling them, if you will. And you have long telomeres controlling that rate of turnover. But as your cells get older, the telomeres shorten and they change the pattern of gene expression. The rate of molecular turnover goes down. The recycling rate of any set of molecules go down. And the result is you begin to get slower, you begin to get more and more accumulation of damage over time. And in really old cells, that happens. The telomeres gets very short and damage gets greater and greater. It's not because there's more damage occurring, it's because you're no longer recycling it as fast. If you want to look at it mathematically, you can do it this way. This is from my textbook. And in short, all this says is in young cells, if things are turned over very quickly, then at equilibrium, you don't have much in the way of damage. Whereas in older cells, if the turnover is slow, then over time at equilibrium, you have a lot more damage, which is why, as I say, my collagen and elastin begins to show wrinkles at my age where it didn't at age 10. It's not the rate of damage. It's the fact that I'm just not turning things over as fast. So to take an example of dementias, this is Alzheimer's. Alzheimer's shows beta amyloid plaque. And what's going on is that in young cells, you're continually making beta amyloid, excreting it from the cell out to around the neuron, then binding it, bringing it back into the cell and breaking it down again. That's a continual recycling process. But as you get older, this happens. The rate of turnover goes down. We've measured it. The outcome is some of those beta amyloid molecules begin to stick together and form microaggregates. Now, you might say, what about the difference genetically? We know that people with certain genes, ApoE2 alleles, have less of this, and ApoE4 alleles have more of this. This is what's going on. If you have ApoE2 genes, what you're doing is you're making molecules that aren't very sticky, so they don't damage very quickly. So even though you're getting slower and slower turnover, at age 100, you still may not have enough of it to form plaque and have Alzheimer's. Whereas if you have two ApoE2 alleles, you tend to make very sticky molecules. So they stick together even, for example, at age 50 or 55, whereas somebody else with better genes does not. But even though genes have a huge effect, it's still this rate of turnover that's the biggest effect. And when it gets slow enough in age, you begin to get not only these little microaggregates, but you get actual plaques, and they begin to damage actual cell function. And the same is true of anything else we look at, whether we're looking at tau tangles or mitochondrial function or any other measure we're looking at in dementias. All of these show slower and slower turnover and more accumulation of damage. And the outcome of that is loss of synapses, dysfunctional neurons, dead neurons, and what we all see clinically, which is patients with Alzheimer's, Parkinson's, and so forth. We can also look inside the cells, and the same thing happens within them. About 99% of all the aerobic enzymes that you make to make energy in your cells come from the nucleus, and they're all turned down in their rate of recycling. So when they sit around the mitochondria for a while, they begin to accumulate some damage as we get older, so they make less and less energy, ATP, and more free radicals, reactive oxygen species. Not only does that happen, but the lipid membranes that surround your mitochondria and defend them become leakier because they begin to get oxidized, and they're also turning over more slowly. So you're making more free radicals, you're leaking them out into the cell and into the nucleus, and you've got scavenger molecules like catalase and superoxide dismutase. They're also slower and slower in their turnover, more and more damage, less and less functional. So they're not catching the free radicals. And finally, as they create damage, the molecules they damage aren't being turned over as well either. Now, almost all the molecules in your body, you don't repair, you simply turn them over. And all that turnover is getting slower and slower with age. There is one set of molecules you actually repair, and those are DNA. In every cell in your body, since I started talking to you about 25 minutes ago, every single cell in your body has shown genetic damage since we started talking. And you have repaired it almost flawlessly, thank God. And the way you do that is with these 4 families of enzymes. You detect it, you cut it out, you put another one in, and then you tie it into place again. All 4 of those families slow down the rate of recycling as you get older. So you're less and less apt to be able to detect it, to excise it, to replace it, and to ligate it into place. So these are multiplicative processes. Every one of those are failing, and they have an impact on the next step as well. So you get this exponential increase in cancer. And it doesn't matter how many years go by, it's how old you are. So whether you're a 2-year-old mouse or a 100-year-old human, you have this exponential increase in cancer. It's not the timing, it's the damage that occurs. You might even say that for most of us, cancer is partly related to how functional your DNA repair is, but it's not simply a matter of exposure to carcinogens. We don't get cancer at age 100 because we've got a lifetime exposure to carcinogens. We've got cancer at age 100 largely, or at any other age as we get older, largely because we failed to repair the DNA damage. It's not the carcinogens, it's our inability to fix things. Now, I've talked a little bit about telomeres. They're at the end of your chromosome, and they set the pace. But I have to tell you that telomeres do not cause aging at the cellular level or any other level. Telomeres no more cause aging than genes cause evolution. Genes are a key part of evolution, but they're not the cause of evolution. Telomeres are a key part of aging, but they're not the cause of it. So talk about causation in aging or causation in evolution is to sort of use a simplistic concept for what's a very complicated process. So telomeres don't cause aging, but they are a key player in it. Also, telomere length is irrelevant. It doesn't matter how long your telomeres are. The question is, how much have you lost? It is not a matter of absolute telomere length, it's relative telomere length. And in fact, the rate of telomere loss absolutely predicts species lifespan, whether you're looking at humans, gorillas, flamingos, dogs, mice. Telomere length doesn't matter. To give you an example of this, there are actual breeds of mice that have telomeres at birth that are 10 times longer than mine, and yet they have lifespans 40 times shorter than mine. It's not the length that matters, it's the change in length and what they do to gene expression and what that does to molecular turnover. That's what causes aging in some sense. This is a complicated diagram taken from a recent article that I put out, we'll talk about in a moment. You can mostly ignore it. What it says is that there are a lot of upstream things that have a role in cell aging, and there are a lot of downstream things that occur. Upstream things, for example, trauma. As I say, if you have head trauma, you have a higher risk of Alzheimer's or Parkinson's. Likewise, radiation exposure, infections, genetic predispositions, exposure to toxins, chemotherapy, all of those things. Or to use another example, in other systems, if you have trauma, that increases your risk of osteoarthritis to your knee. If you have hypertension and hyperglycemia, that increases your risk of stroke and vascular aging. What it says then is that those increase the risk of cell aging, short telomeres, altered pattern in gene expression, cell dysfunction, and you get all these things downstream. And I've mostly listed things that bear on dementias, but there are many others too. None of this matters. In some sense, what matters to me is not all of these little details about aging. What matters to me most is where's the single most effective point of intervention, clinically and financially? How can we make people's lives better? That's an interesting question. And the answer is the upstream targets and downstream targets are not very efficient. An example, we have for hundreds of years been trying to control people's blood pressure and their blood sugars. And even when we do that maximally, we don't prevent vascular aging. And we certainly don't prevent things like strokes. The same thing is true when we limit your exposure to trauma. If I make sure you never have head trauma, you may still get Alzheimer's. You may have Alzheimer's, no head trauma. You may have head trauma and no Alzheimer's. So they're not efficient targets. They're fairly good targets clinically. They're just not good enough. They're not absolute. The same is true downstream. There have now been more than 1,100 interventional trials aimed at things like beta amyloid and tau tangles. Not one of those has ever been shown to alter the course of the disease for Alzheimer's disease. So they're not efficient targets. The most efficient target turns out to be cell aging itself. If we can actually intervene in the process of cell aging at the cellular genetic level, we can actually have quite an effect. And this actually works. There's good solid data and proof of concept. We've already found that 22 years ago, we can reset cell aging in human beings in the lab. 20 years ago this year, we showed that we could reset tissue aging in human beings in the lab. The question is, can we do it in animals? That was first done at least partially now 9 years ago, and then repeated 8 years ago using techniques that we can use. And in fact, we know that when we try that in animals, we can reset senescent cells, restore neural function, and actually reverse cognitive decline in animals. So it's effective. The question is, can we make it effective in human beings? Well, that brings me to this article. This is the article that the editors asked me to write. It came out in January. To my surprise, it generated more than 600 global reprint requests, which has never happened, 24 requests to give talks like this one, and a dozen inquiries from people interested in investing. But what I'm really saying is that we now have a model that is consistent with all the data we've got, clinical and otherwise. It's predictively valid. It actually predicted the results for the Eli Lilly trials and the Biogen Eastside study, and it offers us a much more innovative, effective, and feasible target for clinical intervention. In short, I think we can take this to human trials and show that we can both cure and prevent dementias. Now, as I said at the NIH 24 years ago, and I say again now, the fact that this model is logical, rational, consistent with the data is very good, but it's not good enough. Data is better. I don't care how good the logic is. The question is, does the data support it? So we intend to take it to human trials, and we'll see if we can find out and prove we can. I'd like to thank all of you for listening to me. Thank Dr. Chesko and the organizers, and to all of you for being patient. And I will now take any questions anybody might have, and otherwise I'll go back to my cat. Thank you very much.
Meet you, sir. I own 2 of your books. And even though I'm aging, I still found them a fount of optimism. I would like to make 4 extremely brief comments and then ask you a question, if you will bear with me. The first comment I would like to make is about the misuse of the word entropy. Not in your presentation, mind you, generally. Entropy is an extensive property of closed physical systems, not of open ones. We now consider that most open systems are likely to develop negentropy as much as entropy. Following the work of Stephen Hawking, we even believe that black holes are negentropic, not entropic. So the human body being an open system by any possible definition of the phrase, I think the very use of a thermodynamic extensive parameter like entropy is probably flawed from a physicist's point of view. That's the first comment I would like to make. The second comment I would like to make is that laymen and even medical doctors, as you well know, much better than me, of course, often confuse conditions attendant upon aging with the process of aging. So there are many medical conditions that evolve. They are somehow correlated to aging or the outcome of aging, or have nothing to do with aging, but chronologically co-appear, coterminous with aging. But they're confuted and conflated with aging. People say this is aging.
Yes.
That's the second comment I'd like to make. The third comment I'd like to make, and please, apologies for taxing your patience. The third comment I would like to make is again, confusion between system and components. We know that components give rise to emergent phenomena, epiphenomena, which are not reducible. And therefore, system knowledge or knowledge of the system is not necessarily commensurate with knowledge of the components, and even not commensurate with knowledge of components and the processes between the components, the interactions. These are 2 utterly separate domains, as we know from physics and other fields, even in psychology. This is my third comment. My fourth comment, and then the question, I promise. My fourth comment, my field, recently at least, my field is narcissistic disorders of the self. And I have this nagging feeling, no offense, that this preoccupation with aging, reversing aging, confronting aging, eliminating aging, regarding aging as a disease process or whatever, may, mind you, be a bit narcissistic, a bit grandiose, and a bit too self-centered, or perhaps I'm old-fashioned, and but I have this unease when I hear about these things. Now to the question: what did you learn from having studied progeria? What are the lessons from this condition?
For me, frustration. You know, back in the early 80s, late 70s, I had all the world's progeria under my bed, actually. And then I began to see these children. We pull them together from all over the world. And it was frustrating in many senses. One is, typically we'd see about 36 cases a year. And of course, they continually die off. So you wouldn't see these children, some of my favorites in the world. That was frustrating. The second frustration was that I knew that if there were 36 children we identified, that meant that there were hundreds more out there. You know, if I'm a doctor in Chad, if I'm a mother in Chad and my child has progeria, I don't know what it is. If I worried and I wanted to take it to a doctor, I might have to walk for 30 miles to find a doctor. That doctor would then not know what it was. If they knew what it was, they wouldn't know who to call. If they called, they might have problems communicating to find someone to talk to about this. And in short, that meant that there were a lot of cases out there that we weren't seeing. Now, that was a frustration in a sense, but as I say, we couldn't do anything about it. It was like trying to deal with polio in 1950. There was very little we could do about it. It was nice to identify it, thank you, but now what? So it was continual frustration for me. It was also frustrating because I recognized that many people, and this will come back to your comment about aging as a disease, many people felt that it wasn't really aging. All right, so it's aging or not aging, but it clearly has something to do with aging that's intriguing. And the question is, what exactly is that? To your comment about aging as a disease, I find that always funny. The argument, not your comment, but the argument about it, because I find it to be irrelevant in a sense. That is, whether you define aging as a disease, aging as not a disease, I find that the biologists, for example, who are most vehement about aging not being a disease are the same ones who get Botox, dye their gray hair. Right, you know, it's like arguing about is menopause a disease, and yet somebody will treat hot flashes. So is it a disease? To me, that's not relevant. The question is, can we make people's lives better? And I think that same thing is true with regard to aging. I have no interest in reversing aging as reversing aging. The question I have is, can we make people's lives better? So, you know, if Marcus Aurelius, back 2,000 years ago, said, you know, whether you live 50 years or 500 years, it's all the same. It's a question of, you have a life. And I think that's true here. The question is, can we improve the quality of life, not the length of it? I have no interest in living to be 1,000 years old versus dying tomorrow, but I would like to make sure that I don't, for example, have arthritis. I can remember, you know, my own name. That to me matters. It is making people's lives better, not making people's lives longer.
That's the distinction I made between conditions and aging. Conditions are attendant upon aging and aging.
Yes, and you know, I see this, Aubrey de Grey is a classic. He'll put together these conferences on hallmarks of aging. I cannot imagine putting together a conference in 1950 on hallmarks of polio. I don't care. Mm-hmm. It's not a matter of how do we define polio? How are the hallmarks of polio? The question is, can we come up with a Salk vaccine followed by a Sabin vaccine? That's a good question. Or as I sometimes say, the issue in 1952 should not have been, can we develop better leg braces and a better iron lung? That's good, I'm glad. I want to cure it, not simply give you better leg braces. The same for me is true of age-related diseases, particularly the dementias.
Thank you.
Dr. Michael, thank you very much. Okay, may I continue to share my opinions and feedback about your presentation?
Please.
Okay, thank you very much. So thank you very much for these wonderful clinical explanations in your presentation. It was touched me one thing in your slide that you used. I noted this when you said everything worked in mice, but nothing works in humans. And I want to go and to describe this, that it's actually, for me, it's a very true. Yes, everything works in mice, but nothing works in humans. So I'm not going to ask the question why, because you already explained in very details. But usually people are asking why something is not working if we are taking in consideration that all in the medical fields, everything is starting working, discovering and doing laboratory checkups first with mice, and then they are trying to bring to the humans. I was thinking that I think when we are trying to see this and to understand better is not only to invest and to do the investigations, but first of all, as you said, we need to understand. And for me, it's very important, these four dilemmas. The first is that, what is our genetics? How much we know our genetics? How is working our genetics? But not only this, but the second dilemma is, what are we doing with ourselves? Even that we know our genetics, do we try something to do to change or to accept this? How is it? The third dilemma is with whom we are living and where we are living. What are the conditions that we are living, and we are taking in consideration all these things, even that we have our genetics, even that we are doing what we are doing. And the fourth dilemma is that actually we know something, but we don't know yet, or we don't know what is the end. This is probably a very good example with those days that we have the virus here, and infectologists are saying that this is something new, that we don't know exactly how is and what will be. So all the time it's coming something new and new. So this fourth dilemma for me, it's that we know something, but we don't know nothing. This was my comment about that. I don't know what you are thinking about that.
I don't know. I mean, two things actually came to mind. One is a humorous remark I made in Washington, which is I realized when we were talking about animal models that whether it's mice, rats, dogs, cats, rhesus monkeys, gorillas, humans,
yeah.
At one point or another in my life, I had been bitten by all of them, including human beings, and I don't just mean children. But the other was that, when I'm looking at the difference between different species and how things play out in different species, the same is true of human beings. I mean, as you and I well know, if I've got 100 patients with depression, I cannot use the same medication for all of them. They all respond different ways. Well, that's again because we're all different. And I could say that it's because we're different genetically and epigenetically, and that's true. Our diets, everything. But the point remains, we are not, you can talk about precision medicine, maybe nail that down, but we are all different. And it's not, unless you account for those differences and the complexity of it, you're never going to be able to do something like generically treat depression.